Dr. Somashekhar Reddy, sir, President of Twin Cities Orthopaedic Society.
Sir. Good morning, respected seniors, teachers, colleagues, and youngsters. I welcome you all to this hybrid meeting after nearly 18 months of hiatus due to obvious reasons we all know, and just beginning to venture into the physical side of the conferences now, and hopefully we'll go back to our old system of having physical meetings hopefully in the near future. And I welcome you all, and I hope you participate and get the benefit from these meetings like before. Thank you all.
Without any delay, we'll go with the first session, that is 3D printing, the new technology which can be used in complex orthopedic surgeries. It is going to be like a symposium by Anatomize. We have Karan here who will take us through 3D printing introduction. Over to you, Karan.
Good morning, everyone. Thank you so much for having us. I'm Karan from Team Anatomize. First of all, I would like to thank the TCOS team, Dr. Srinivas Kasha, Dr. Somashekhar, for having us here to introduce the 3D printing technology. So Anatomize 3D, it's been a 7 years journey for us, starting that we did from a pediatric heart. Just a second, I'll connect the presentation. I hope everybody is able to see my presentation. So as I said, yes, I'm Karan from Anatomize 3D. This is our meeting, sir. We are working since 7 years into medical. So since 7 years, we have been doing patient-specific model. That has been our main focus area and the vision of the company, that we deal with patient-specific care, help diagnostics companies to manufacture better implants for the surgeons to work on the patients. Just to introduce, we have been, we started our first case with a pediatric heart 7 years back. It was a patient with DORV, and that is where the patient was being declined for surgery 3 times, and then at Fortis Hospital in Bombay, the surgeon approached us. We made the model. So after the model was made, surgeon not only found out that the surgery is possible, but a full correction is possible. That is when we thought that this is the field that we would like to go in and help the doctors and the patients for improved medical care. With that, we kept on our journey. We're doing a lot of first cases in India, printing cases in India, along with a lot of doctors. Couple of things that we brought in new with the help of the doctors and the diagnostics company, like molds for cranial implants and other things. Across 7 years, we have been catering to over 1,400 plus patients across the country. There are 5 medical devices companies, pharma companies who work with us for designing, doing the R&D and also patient care. More than 300 plus doctors have been working with us day in, day out to improve the patient care across the country. Hospitals, many hospitals across the country, be it standalone hospitals working with us individually or doctors working with the hospitals. So 100 plus big hospitals are working with us. These are a couple of clients that we work with. So if you see Tata Memorial Hospital, so Tata, we also have a setup where 3D printing is in-house. They are designers with them to improve the patient care. AIM Hospital, JJ Hospital in Bombay, Apollo Hospitals, Hyderabad, Max. And if you see a couple of companies like Brown, Stryker, Medtronics, we work with them on the R&D to improve the devices that the doctors work with. These are a couple of publications that we have done across the years. This is a core team. So there are about 21 people in Anatomized team coming with designers, biotech engineers, support staff for printing. Our main office is based in Bombay, but we have some offices in Hyderabad. Have a slice thickness of 1 or less. The important thing over there is if the slice thickness is more, say about 4 or 5, which many of the diagnostic centers outside do, a lot of data has been lost between those slides. Then it becomes very difficult to give you the accurate model to do the planning on. So when we get the data, we require a slice thickness of 1 mm. We can work with CT separately. We can work with MRI separately. If there are cases like tumor where on the bone and all, where you need to superimpose, so the bone and the soft tissue is to be merged, we can work with both CT and MRI. We can superimpose the data and see to that you get the accurate anatomy out. Once the data has been taken, because of the digital era, the data can be transferred online. So we have a link on our website, or we transfer, or there are a couple of more softwares through which you can upload the data and send it to us via mail. That is preferred so that the time is reduced between the data acquisition. If not, we can also work with the CDs. So we can collect the CDs, it can be couriered or hand delivered, and we can work with that. So once the data is with us, our designers download it. First thing is they communicate with the doctor, take his idea what actually he wants out of the model. So we discuss with the doctor what he wants, if there are jigs, guides required for it. Then the designer designs the entire design for the model. So model can be a regular anatomy model for planning, visualization. It can have jigs, guides, where cutting is required in say fractures is there, tumor is there, plates are required. After designing this, we confirm with the doctor that the designing cut section, what he is looking for is accurate or no. Then we go for printing. Printing, as I said, the technology can be selected depending on what output the doctor wants. It can be a plastic, it can be metal, it can be soft model, a mix of both. That printing is across the surgeon for his planning. Anatomize over the period of 7 years. Initially, as I said, we started with pediatric heart, but with the help of a lot of surgeons across the country, we were able to cater to a lot of different specialties over the time. So today at a menu, we cater to orthopedic, ortho, onco, neuro, cardiac, spine, pulmonology, urology. So I could say it's an entire portfolio that we have for all specialties, where it can be a soft model, hard model, that is bone, tumors, cutting guide. So if you see, anatomy is there, cutting drilling guides are there. We also do titanium implants. So where the patient is to be after the treatment of tumor, or if there's a defect, fracture, you need to replace that with implants. We do titanium implants, also new things like cranial helmets we work with. So overall, we over the past 7 years, initially that is the cost. We are trying to reduce our cost drastically so that the technology is being used widely to improve the patient care. Initially, if a regular model of a bone, say a knee surgery model, if you need a knee, that would cost you about 15,000-20,000. Now we have reduced that with a lot of help of surgeons, Apollo, to about 5,000 rupees now. So if you are looking for a model like a knee model to plan surgery, a bone model which is there, that would come at about 5,000 rupees, which is there. So if you see drastically, we have been reducing down the cost to almost 1/4, so that surgeons can use widely to improve the patient care. I'll now hand over my mic to my colleague Parinita. She will take you ahead with how generally we design, what communications we do with the doctor to do the designing and make the models. I'll hand over the mic to Parinita.
Thank you, Karan. So I'm here basically to run you through the process of how we generally design, how the process flows right after data acquisition, what is that we do until the final model is being printed. Give me a minute because I'm going to just change the screens from the presentation to the software. I hope the screen is visible to all. So basically, this is a CT that we had received. So basically, I'm going to talk about a case wherein the patient was suffering from tumor at the sacral region. So I'll just walk through the slices of the CT so we get an idea of where the tumor was exactly located. So just running through the slices and the axial view. So what we notice is that in the CT, we do not get the exact margins of the tumor, right? We're just getting a very hazy border here to understand what exactly are we, some basic borders that we're getting here of the tumor, not the exact coverage or not the exact dimensions. So in such cases, what we do is we just construct the 3D model from the CT. So here you can see, this is a 3D model of only the bone being extracted from the CT. So I'm just going to run through different views. So this is anterior. I'll show the posterior because that is exactly where you can see the disease section. But just a very well-defined border of the CT. CT gives us the bone. Now I'm going to share my screen and show the MRI. So when I come to the MRI data, here what I can see is a very good margin of the soft tissue. So I'm zooming in on the axial cuts, and here we can see the margins of the soft tissue. So what we do is we do a superimposition of this soft tissue tumor onto the CT. So basically what this helps us is to get the correct margins of the CT on the bone. So just quickly hide all of these components. So basically this, what you're seeing on the screen are the components that are derived from the MRI, the soft tissue tumor in green and a section of the femur from the MRI. What we do is we use this femur as our component to superimpose data onto the bone. So you can see, I'll just change the view. So a section of the femur that was taken from the MRI has been superimposed as a point-to-point registration. So the femur of the CT and the femur of the MRI forms our landmark registration or point of registration, which help us identify whether the superimposition that we have done is accurate or not. So based on this, this is how we superimpose and get the data. So I'll just quickly show different views. So we have a fair idea. So once we have identified the location and we have superimposed our data, this is where we proceed with the next step. That is the planning. So by planning is, I mean the cut section planning, because here the requirement was to get a colored model so that the surgeon understands the border of the tumor onto the anatomy model that we will be printing, and also to get a cutting guide. So here, as per the surgeon's report, we have taken approximately 5 mm cuts. So these cut planes are approximately 5 mm. So I'll just take a top view. So you can understand from this the extent of the cuts. So these form our base planes. So this is the region where beyond that, this is the minimum cut plane that is required by the surgeon. So these 3 planes, it's almost like a triangular cut, as you can see. So based on these planes is where we decide that this is the minimum area wherein the tumor lies, and beyond this is the what we say the safe margin or the bone resection plane. So these cuts were final meeting and taken inputs. Based on these inputs is where, you know, once the surgeon has confirmed that this is how he wants to proceed with, is when we go ahead the cut planes. based on cut planes, these cut planes, of course, get a thickness of the saw thickness, generally 1 mm or 1.5 as required. Or sometimes if you're using an osteotome, we give you a slit or a window that will accommodate your osteotome. So going into that. So considering this current cut planes, this is the bone margin. If you can see the cut plane, this is the bone margin that is visible. So this is the region that will be, I'm just keeping the sacrum and hiding the rest of the components. So the superior part is what will be retained and the inferior part is the cut section. Now coming to the jig. So this is how the jig will be placed. I will get the pelvis section back. So I can explain the anchorage that how we have taken. So to give a support to the jig, we've also taken a small region from the crest, as you can see. So here, from the crest, we have taken 2 sections for anchorage. The slots that you see or the holes that you see are for K-wire fixation. Anteriorly also, on the sacrum, we have given extensions. So these extensions don't necessarily sit on top of the bone. They are floating. So soft tissue is not a problem here, generally. And in case soft tissue coverage does become a problem, what we do is we cut the jig. So you can see here, the jig is technically just on the surface. It's not directly in contact, just one point of contact at the spinous process here. Once the entire jig is ready, we again send a video for confirmation to understand if the anchorage you've taken is optimum or not, whether the cautery in this region for soft tissue will be possible or not. Based on the feedback, if it is approved, then the model and the jig is sent for printing. The jig is generally printed in an autoclavable material and the model is printed in an ETO sterilizable material. So yes, that's majorly it. That's how we generally do our designing. I hope you have some clarity on how we, convert the CT that we receive into a model and then get a jig out of it. I'll now call upon Firoza to continue further.
Thank you, Parinita, for that. Hello, everyone. I am Firoza. I'm one of the co-founders of Anatomize 3D. We started this company 7 years ago, as mentioned. In the interest of time, I am going to just quickly run through a few applications because I would want Dr. Rajeev Reddy to share his experience more. So we'll just quickly speak about certain products. Since we've been doing this for 7 years, some of these products are, some of these case studies are almost 7 years old. So we'll also be able to see the evolution of how 3D printing has evolved over these years. So the first kind of application that we see is anatomy models, which is basically the patient's anatomy itself extracted out of the CT or MRI, converted to a 3D model and used by the surgeon to plan his or her surgery. Yeah, to plan his or her surgery. So this could be any type of cases. These could be fractures or trauma. This could be tumors. These could be revision surgeries or any kind of deformation surgeries. As Parinita has already explained the design process, I will skip through that. Let's discuss one of the first few cases that we did in orthopedics. This was a femur model with an acetabulum cup, which was so small that we were not sure if a prosthesis would actually fit onto that acetabulum cup or not. So the model was made, this same model was actually rimmed through the acetabulum, and then the implant was placed over there to actually find out that the smallest implant was fitting for that patient. So not only does it help to plan the surgery a particular way, but it also tells you whether a surgery is possible or not in many cases. So this is one of those examples. Second one is arthroplasty. So here there was a deformed scapula, and then there was a good side of the patient's scapula. So to be able to do that reverse arthroplasty, both the sides of the models were created. So using the good side, the deformed side was reconstructed accordingly. Then comes different types of fractures. There are tibia fractures, femur fractures, acetabulum fractures. I mean, depending on the kind of damage that has been done to the patient, the models can help accordingly. Next one is any kind of revision surgeries. So if there are any implants existing in the patient's body, could be bone cements, could be any kind of metal, majorly titanium is what we see. So if those are also there and if they need to go for revision surgery and the planning needs to be done, how much of the bone is damaged or how much of the bone is remaining? And if there is any implant breakage, then how has it broken? Those kinds of information can also be received from such models. This is one of the cases which we did with Dr. Kasha. Again, it was revision surgery with a fracture, and you can see small implants onto that model. Including soft tissues onto the models is also possible. So having the cartilage reconstructed, having the ligaments reconstructed, muscles around it with the tumors as we saw earlier. Even if we want to see the nerves, so we then superimpose the CT on MRI, and in a way a combination model can also be made, including hard bone and soft tissues. These are some cases that Dr. Rajeev is going to speak about, so I can skip through these. Again, here this is another case of the pelvis tumor model, where a jig was created with complex angulatures to be achieved, which may not have been possible or may not have been fast enough without a jig surgery. But with the jigs, it just made it faster. Some more cases. However, here I would like to highlight that if you'll see the last image on the right, you're also seeing a customized titanium. And then it goes for ECRT procedure for radiation for a tumor case. You are inducing a fracture. So when you bring it back and you have to place all the bones together, a regular implant or a standard implant, which is partially pre-contoured, you'll have to end up bending it onto the table, which is definitely a time-consuming process, plus the fitment may or may not be extremely accurate. So here with these pre-contoured implants, which are directly designed on the computer and printed in titanium, this helps actually fit the bone back as a snap. So maybe a procedure which could have been about 45 minutes to 1 hour can be reduced down to 10 minutes with an implant like this. So the next thing we also do is spine jigs. So to be able to give guidance systems for the pedicle screws to go through, say, a scoliosis case, a kyphosis case, and to exactly understand the length, entry point, angle, and diameter of those pedicle screws that you would be putting into the spine. As I was mentioning about the custom implants earlier, we also do some custom implants for load-bearing cases, wherein you're seeing the pelvis case in the center. We do not replace the existing standard implants. There is no need to replace the standard implants completely. They are quite good. However, in cases where standard implants do not suffice that kind of a case requirement, for example, in tumors of very complex tertiary fractures, that is where 3D printing can come into the picture to replace that area of interest in combination with a standard implant. So here, if you will see the hip implant that we are showing, the component which is fitting onto the pelvis is 3D printed. However, the femur model, the femur side of the implant is a standard implant along with the cup that fits into the 3D printed implant. So we designed the cup in such a way that a standard implant cup can fit into it, and then a femoral head shaft can be used from an external implant. There are also certain cases of complete scapular replacements that we have done, which also have addition to the clavicle, as you can see from here. So with that, I just have two more things to speak about. Until now, we spoke completely about patient-specific approach. However, this technology can also really be helpful in workshops. So we all understand that cadavers, I mean, there's one cadaver, multiple students wanting to study on that. Getting the bone models also are not very easy. And diseased bone models are even more difficult. So if we want to have a concentrated workshop, something like this, considering all the cases that have been done before from your past, can be converted to a model to be taught to your peers or the students. And we can try and achieve as close to bone density and the soft tissues around it as possible. And also, setting up point of care labs is something that we have started about 2 years ago. So right now, as a service bureau, we are outside. However, being inside the hospital may also be very beneficial to different surgeons around and to different patients who come in, because they can get that kind of faster 3D reconstructions, and patients can also feel that they are able to communicate on that 3D model with the surgeons. So with that, I'd just like to call upon Dr. Rajeev Reddy to share his experience.
Good morning, everybody. Thank you to TCOS, Dr. Somashekhar Reddy sir, and as well as Dr. Srinivas Kasha sir for giving us this opportunity. And I would like to share a little bit of my experience with the 3D printing as well as with Anatomize, because we've been doing 3D models with Anatomize since my fellowship training with Dr. Manish Agarwal in Mumbai, and the amazing results that we have had clinically with Anatomize have made it ubiquitous in our clinical practice, and most orthopedic oncologists have now been using 3D printed models as well as plates across the country for their surgeries. So when we see a young lady like this, a 32-year-old lady who presents to us with the history that she's been having left hip, left hemipelvis pain and swelling since the past 2 months, which has increased since the past 2 months. She also gave us history that she had undergone surgery for similar symptoms 2 years ago, following which these symptoms have now recurred. The histopathology is the most important aspect of any investigation for an orthopedic oncologist. So when we went back and checked the histopathology reports that were available 2 years ago, it was reported as a low-grade chondrosarcoma by a very experienced pathologist. So these are the initial X-rays which we could view. On these X-rays, we can make out that there is some fluffy calcification around the left hemipelvis, but the X-ray did not give us any more investigation. Given that this diagnosis is chondrosarcoma, we first did a PET scan to see what this patient's prognosis is, whether there's metastasis and what is happening in the pelvis. And we could make out that there is activity and there is disease only at the left hemipelvis. And we went in with a curative intent. The most important investigation for any bone tumor is an MRI scan, and we could make out on the MR images that there was a huge swelling which was extending from the gluteal region across the sciatic notch into the pelvis. And this looked like a fairly well-defined swelling, which was very bright, indicating that this is a chondroid tumor. Further coronal sections did show us that this tumor was separate. It had good facial planes from the rectum as well. So at this stage, what we wanted to know was whether there is one tumor or whether there are multiple nodules, and how do we get a good 3D orientation of this model. When we got a CT scan done, and these are the routine 3D images that we get from CT scans, we could make out that there is a calcification and ossification posteriorly as well as anterior and in the sciatic notch. But this is all the information that we could get from a 3D model from a regular CT scan. Compared to that, because our plan of surgery is a wide excision, this patient has already had a recurrence and she's very young, and chondrosarcoma being a low-grade tumor, this patient is going to live for a very long time and she needs a wide excision. At the same time, our aim was to save as much normal pelvic bone as possible so that she walks with a good gait and she doesn't have any injury to the sciatic nerve, especially because it was running through the sciatic notch. The tumor was going into the sciatic notch in a dumbbell way. And of course, the vascular structure should not be compromised. So then we asked Anatomize to make a model for us and to show the two in red color and the normal pelvis in white color, so that this could help us on table. And after discussing with Firoza and her team, we were able to tell them, as they had just shown us, as to tumor is on the MRI as well as the CT images and the areas that are normal bone. And because we've been interacting with them for a long time, they are now as good as anybody in identifying the normal bone, sometimes better than us in identifying the tumor from the normal bone. And their inputs are quite valuable. When this kind of a model is made, it makes things easier not only for the surgeon, but also for the patient, because we can counsel them. Already anxious patient who's had a tumor, who's in the reproductive age group, we need to tell them where the tumor is and how the tumor is close to the nerves and whether there can be nerve related damage. So for a layman, this kind of a model sitting in front of them and explaining to them, things become very easy, especially because it doesn't come at a great cost. It's around 10,000 rupees, which, given that these surgeries are expensive, is something that is not very expensive. Also, this helps the operating team, because everybody, right from the juniors who are assisting the case to the sisters and the operating personnel, are aware now as to what the surgery is, because in many cases the 3D image of the tumor is formed only in the surgeon's mind, and the other people are lost because it's such a complex region with complex anatomy. So we can see in this, the tumor is overhanging the sacrum as well as the ilium and extending through the sciatic notch into the intrapelvic part. We went ahead and used an extensive posterior as well as ilioinguinal approach, and we were able to dissect out the tumor, and we always send intra-op frozen margins, and those were negative. And this tumor was later sent for histopathology, which confirmed that this is a chondrosarcoma, grade 2 chondrosarcoma. And the entire neurovascular bundle was saved, all the sacral nerves as well as the sciatic nerve. The immense impact that this kind of a model has during surgery is that it decreases the stress and it helps everybody get a good orientation, and the surgery becomes quicker and safer. Also, in cases where we remove the bone and send it for radiation and put it back, something that is now become the bread and butter for orthopedic oncosurgeons, it is easier if we have a 3D model which is available on table, so that we can contour these plates and we can practice this on table before we actually put the bone back into the body and use these recon plates for reconstruction. We all know that extracorporeal radiation is being done routinely now, especially in diaphyseal tumors, where we resect the tumor, and once the tumor is resected, we send it to the radiation department in this sterile packaging, where the radiation oncologist gives 50 gray radiation for 25 minutes immediately. During that time, we harvest the same side fibula, cortical fibula, and once the radiated bone is back, it looks like this with the telescoped cortical fibula inside it. And we put it back into the body with a long plate. Now, these plates which we have been using previously have been the regular plates that are available off the shelf from various companies. The problem that we have had with these plates is that this bone which is radiated and put back is not always in the same shape as same anatomy as a regular bone. Most of the times they either have a deformity or the tumor causes a periosteal reaction, which if we try to remove on table with a burr or osteotomes, ends up fracturing the bone. So it's not the bone that we need to modify, or it's not the bone that we need to change. It's the plates that we need to change. The plates need to be shaped such that they fit this particular bone. Like in this patient, we can see that on the medial side, this patient has an abnormal bulge in the bone, which if we try to if you're planning to put a medial plate, it's very difficult to put a plate over here using the regular plates. And if we try to shape this or contour this bone, it will fracture a radiated bone, which is already weak in any case. So this is a compromise that we have to make on table. But when we use plates like this, as we have used previously with Dr. Manish Agarwal, these are plates which are made specifically for the patient. And the length, the width, as well as the proximal screw holes, the distal screw holes, the number of holes are all made customized to the patient. And this helps us in fixing the radiated bone back quickly and in a more accurate way, so that we don't have to compromise, we don't have to contour and on table and fight with the plates. Similarly, a case like this is a doctor who is 28-year-old, and he's been having this exostosis and osteochondroma in a difficult location, arising from the fibula neck and going posteriorly around the fibula and into the posterior surface of tibia. common peroneal nerve, the popliteal neurovascular bundle are all around these structures. And we know that an osteochondroma of this size means that there can be no mistake in spilling the tumor. It's a cartilage component, the white part of the osteochondroma, which is the malignant part. So spilling it will definitely cause a recurrence. And because he's been noticing it since 5 years, he was advised 5 years ago, but being a surgeon himself, a urologist himself, he decided that surgery is not safe. He refused surgery at that time. Now he is concerned that the swelling is increasing in size. In this kind of a situation, if we have a model with us which shows not only the tumor but also the popliteal neurovascular bundle, then our coordination with not only the patient but also the vascular team, which is on standby, becomes better, because they know where the trifurcation point of the posterior anterior tibial and the peroneal artery are with respect to the fibula, and the chances of developing complications is less. What we should remember is that proximal fibular tumors or proximal fibular surgeries are generally taken very lightly. But as any orthopedic oncologist will tell us, the highest rates of amputation are with proximal fibular tumors, and the highest rates of complications are with proximal fibular tumors, because damaging the posterior tibial or anterior tibial, in many cases, even after repair or reconstructing it, the flow may not be as good as expected, and that can lead to an amputation. So and with such neurovascular bundle so close by, it's ideal to have such a specimen in front of you, which will tell us the relation of the neurovascular bundle to the tumor. So this model was prepared by anatomists, and we could make out that the tumor is arising anteriorly from the fibular neck going into the interosseous space. And this is exactly the area where we know that the anterior tibial, posterior tibial, and peroneal divide from the posterior tibial, from the main popliteal artery, and it is going posteriorly and sticking to the posterior surface of the tibia. So our approach to the surgery, our positioning, as well as our entire surgery is now made easier because we have this model in front of us. So as we all know, this was the only phone that was available when I was a child, and having this meant that you're at a different level, especially when I was in MBBS. But now we have a wide array of phones mobile phones which we can choose from, and we have moved from the earlier Nokia phone. Similarly, the symbol of our own city, being this 100 years, moved on to it being an IT hub, and this being the new symbol of Hyderabad. The only car that was available for a long time in India was this, and now these kind of cars are routinely available. Similarly, it's not that we can ever replace the regular implants or cellular implants that are available to us. They always have a place, but in complex surgeries, especially when we are dealing with revision surgeries, definitely 3D implants have a place to not only the 3D implants, but the 3D models or the 3D PDFs that they create and give us have a huge role to play in planning, because they make surgery easy. They're available at a very affordable cost, and most of the time surgical time is decreased, and that itself reduces the cost of the patient, which can be covered in this particular thing. Thank you very much to TCOS as well as anatomists.
Here is a 45-year-old male had a road traffic accident, and this was the initial X-ray for which surgery was performed elsewhere. After which, so the surgeon has felt it is not sufficient and posted him back and did that after about a week's time. And you can see so many plates, 1, 2, 3, and 4, I think so. And screws we cannot count also. So, and there was a osteotomy done for trochanter too. And within a month's time, it has failed and gradually reached this particular stage and presented to us after 8 months. This is the presenting X-ray. You can see that it's not post-op, post-op third picture, not post-op third day. So this is how he has presented to us, And in this particular thing, although we do regular pelvic surgeries, it is very difficult to have a three-dimensional orientation and the defect. So when you want to reconstruct such a joint, we should know the anatomy of the acetabulum especially, so that the CT scan itself is not sufficient to plan your surgery. So that's when we chose anatomize, and this was the bone model which was created by them. You can see the acetabulum, the posterior wall, only intact thing was anterior column. The posterior wall was in discontinuity and it was displaced medially. You can see the plates are directly seen on the posterior side. There is no posterior wall or column intact. And that was whatever column medial side which is available has gone inside. So got internally rotated. And you don't have anything to support on the posterior side. So again, the same picture you can see. In this particular case, I have actually planned for implant removal because his CRP and ESR were high and he has rest pain. So he has associated infection too. So anything we have to plan, the implant should come out, and next stage, in the first stage, antibiotic cement spacer, and at second stage we have to reconstruct the joint. That was the plan. And so I have removed the plates. This is after removing, I am cutting out the plates with a nibbler here, and just trying to plan what can be done with all the instrumentation and implants that are available. So with augments and everything, I have just tried to reconstruct on, in my outpatient clinic. But you can see the posterior column is very far medially displaced, which don't have any stability which can be restored through the augments. This is just to show that. And the initial first stage, I have removed the posterior plates, and anteriorly also I went ahead and removed the screws, because the initial picture you can see, you can see in the first picture the screws are inside the joint, so that are to come out, and they are coming from medial plate which was applied through Stopa's approach. That was very difficult to re-enter same area through the Stopa's approach, which actually took more than 4.5 to 5 hours, because all that is pasted and fibrosed and plus infection. So, and this is once at a second stage, once the infection has subsided, I have gone back and used MRS Titan modular revision cup from Exatech, wherein which I have used it on the bone model, and then we could do this. And this is 6 weeks post-op stage 2. This is this can be used because there is only thing which is intact was anterior column. The posterior side stability was given through the plate which is available through the processes itself, acetabular component, which is buttressed onto the supraacetabular bone. And this is after a year of follow-up. So this is just to mention, it has got a 3D printing has got a role in pelviacetabular surgery, and especially in planning your complex primary hip replacements and also revision hip replacements where you have a significant bone loss. Thank you. What next? What next? You are done, right? So with this, I thank Anatomized people for their wonderful illustration on 3D printing, their technology, how they process. I was really impressed how they process from MRI also. It's very interesting for us to know. And we'll move ahead with tea break and come back and go ahead with the next session. Before that, Dr. Sujit has come up with one of his friends who is making 3D splints. So we want to have him for 10 minutes on Zoom after the break. Yeah, any questions please to anatomize?
Yeah.
So speak, Mike.
Okay. When you are making this acquiring the data, you should start to find the issue.
Can you come down here?
How do you cope up with that? Because the risk which you are making,
Yes.
the risk which you are making, they are made up based on the data acquired on society.
Right.
But once you make it road and do an osteotomy, everything changes.
Right.
So the angle, the length, the rotation, everything. So how do you cope with that?
Yeah. The question is the CT scan which is done for planning is in supine position, and whereas when you operate it might be in prone position or lateral position.
Usually prone.
Yeah. In respect to spine, it is. How do you address that? That is the question by Dr. Rajeev, sir.
So, sir, every jig that we make specifically for the spine is per vertebrae. So we don't make two different levels in the same jig. So one vertebra with two pedicle entry points on the left or the right. So that way, no matter what position it is, the vertebra single level jig is going to be placed over there. So here, if you see this jig that I have, this will fit onto one of this is the 10. Yeah. So once it fits over here, it fits onto the spinous process of that vertebra and the lat transverse processes in a very small way of that vertebra itself. It will not go on any vertebra up or down. So no matter supine, no matter prone, lateral, whatever orientation the patient is tested, it will not affect in the direction.
No, I am experience and talking because maybe in human surgery you may go a centimeter there, extra centimeters you can excite it. Whereas in spine you tend to be in millimeters.
Correct.
So a millimeter of here and there you are engaging in spine.
Correct.
So this is what makes it a little bit difficult for deformity.
Right. So that's what I mean. So even when we are looking at, say, the deformity correction, scoliosis, kyphosis, those kinds of cases, in this orientation also, say the patient was kept in disorientation while taking the scan. When it comes, this is going to come a little bit, it's going to move a little angle, posterior. But still the vertebra in itself is not changing its dimensions. Yeah. So
he is deformity correction surgeon, by the way. So
no,
what he meant is it's dynamic. So
Yeah.
when prone there is the deformity which changes. So is the answer simple answer could be, can we do a CT scan in prone?
Maybe that's a sensible answer. One thing. Second important thing, you have to find some solutions for this.
Okay.
It does happen. A lot of time, even with the navigation robots, they have also not come up with an answer for these things. Why? Because at least in life surgery, the robot and the patient are placed in live position. So they can register these points very well than with this.
Okay.
That's what you have to find some answer.
We'll look
You are from Mumbai, and a lot of nice surgeons are very to them and try the solution.
I will. Sure. Thank you.
Yeah. So any more questions to anatomize or from the previous talks?
The question regarding cost. Most people want to know what is
Yeah. So even I have the cost. whatever the cost which they have told here, so when I got it done near back, it was almost 4 times.
Yes, so we worked on reducing down the cost.
So it is going to be cheaper now.
It's going to be much cheaper.
As we said initially, because we were trying to see how we can improve the software cost, the cost of the materials, the volume. So industry also, so everything is also depending on the volume, so that the timing comes out. So as I said previously, you correctly said it was almost 4 times. So when saying a model which would cost you 5,000 for a knee model would have cost you about say 20 or 1,000 a couple of months back, or say last year, before the pandemic. But during the pandemic, we were doing brainstorming that how we can see to that more and more doctors use this technology. So that is where we came up with that we were trying to reduce our cost internally as well as outside. So this is how, as you said, we will be reducing it almost by 1/4, 4 times the cost.
Sure, thank you. Any more questions? Yeah, Mike, please.
Good morning, everyone. Sir. I am Dr. Rajeev, currently pursuing my second year residency. My doubt is how much time does it take, like for example, to print a pelvis model?
So the printing time depends on the size. So say a normal, adult male or a female pelvis would take us about 40 hours worth of printing. So in that case, we can always split it into 2 parts and print it in 2 printers so that within 20 hours we can get the builds and then we join together.
And the other thing is, what is the role of 3D printing in acute trauma?
So some of the examples that we had shown over there in terms of understanding where the fragments are, how big the fragments are, the location with respect to the spatial relationship of the bone. Those kinds of cases. However, Dr. Rajeev would be more, could answer this question.
I can answer that.
Yes.
In trauma, it is always surgeon dependent. If you want to see, especially any periarticular trauma, let us say posterolateral depression fracture of tibia or acetabular fractures. So you can choose to get the 3D model, but most of the planning can be done on 3D CT scan itself. But if you want to try and see the implant size and then place it and then check, then probably if it is available next door, something like if it is available in Hyderabad, so we can as well take it in within 2 to 3 days, right?
Yes.
How is the material problem they face is with the material. Suppose you have a material which is almost like a bone, then you can actually practice dissection.
This is almost like a bone, sir. The material which they give, what is that material?
2-3 different types. ABS plastics are there, sandstone materials are there. So these two mimic the properties of a bone in many ways.
And we can even put a plate on that.
Could you get the same thing?
No, not completely same, sir, but we can practice on that.
So this is ABS materials. In this you will not get the complete feel, but you will be able to make the osteotomies. In the other material, the sandstone one which I was saying, there you will get a proper bone feel. However, that is slightly more expensive in terms of the material. So depending on what you want to do at the end application, you could make a choice of what material.
One more question? Yeah.
Sir, while planning surgeries for 2 months, and we print it with overlapping of CT and MRI, is there a possibility that after opening the patient, there might be a difference from what we see in the 3D picture and intraoperative?
Rajeev, we have to answer. So her question is, already MRI, 3D printing is done based on MRI and CT. Is there a scope that you see something different once you open the tumor, or once you open the area?
that is a problem, there's no doubt, but it depends on how well you plan the surgery with the anatomic team before that, because they are after all implementing whatever you tell them, and nothing is going to change in about a week's time. But if you tell them that this is not a tumor and it's a normal bone, they will reconstruct the model accordingly. So it's your idea and what you're thinking of that they put it in terms of a physical model. So if there's a mismatch between the model and the inter-op thing, it is because we have miscalculated the margins or we have miscalculated the tumor extent on imaging. It's not because the 3D model has been created wrongly. Most of the time, what we do is, if we feel that a certain area is very tumor, very normal bone because of edema and other things, we consider that as tumor. And on the model, they will make it and color it like a tumor. But intra-op, it might actually be normal bone, so we can adjust accordingly. So it's better to be over-cautious rather than underplaying it and making it normal.
I think the duration between your scan and the surgery, if you are months apart, then I will know.
As a rule in sarcomas, our scans are always done 2 weeks before the surgery. Even if it is 1 month or so, we can't access the same.
What we do is,
So thank you, Anatomize. I would like you to stay on stage. Sir, Somashekhar sir. So just hand over mementos from KIMS Hospital and TCOS.
Thank you, Rajeev. And the minute I came to know a few months ago that you are being stationed in Nagpal, I was so happy. And I was so happy to welcome you there in the cancer block. And I hope you will really make a good difference to the entire orthopedic specialty of twin Telugu states. Okay, thank you all.
Thank you so much, sir. We hope to be a part of the community.
Yeah, sure.
You would like to?
Yeah, come.
Dr. Rajeev. In case the audience wants to know, it was Dr. Mri Reddy who started his own kitchen sink 3D printing long time back, which he was helping us a lot in the past. But now we got you all the professionals.
Even now he does it for us, and he does many academic things. Okay, right. Welcome back. Without any delay, we'll go ahead with the next talk. Actually, we have added this talk today morning itself. It is about 3D printed customized splints by Create Labs. Mr. Amartya Gupta is going to speak on this. Without any delay, over to you, Mr. Amartya Gupta.
Hey, morning everyone. Thank you for this opportunity and thank you Dr. Sujit for inviting us. So we'll be very quick about this because I know there's a time restriction as well. So our company is called Create Labs and our motto is Innovate to Enable. So just a little bit about us before we get into everything. Our company is founded by Satyam and I and Dr. Vamsi as well. He's an orthopedic surgeon. The three of us met back when we were working in Manipal, and for 2 years we worked on multiple different projects from prosthetics, orthotics, rehab, robotics. And coming out of Manipal, we realized that we've got a good relationship here, we've got good ideas, And so we decided to start a company to put these into the market so that we can make an impact in our society. So the first product that we made, we call it Mithril, which are the Neo 3D printed custom splints. And it's visualized over here. This is the cock-up brace. So as you can see, it's very well ventilated. So it's breathable, completely waterproof, hence hygienic. It's very lightweight and comfortable. And it's customizable as well. And I'm sure you all would know this process of heat forming. So you basically heat the splint up to 70, 80 degrees Celsius and mold it to the patient's hand. And this process takes less than 5 minutes. So if anybody ever wonders why Mithril splints, it's because it's aesthetic, breathable, custom, durable, and economic. And given all of these features, we see that they're especially useful for athletes, post-operatively, for pediatric cases, and most importantly, these are some of the cases. So on the left, you can see is an amateur golfer. So an athlete's case. She had a capitate fracture. 2 weeks into her intervention, she was wearing a cast. The cast got removed, and we were able to provide her with a cock-up brace. And she was able to get back into her light exercises and rehabilitation processes without any discomfort or irritation. Then we had a brachial plexus case. In the early stages, we just gave her a positional cock-up brace. The third one is actually a custom splint we made for a child. This we got from Manipal hospitals here in Bangalore. He had a tumor in over here. And he needed a splint that he could wear pre-op and post-operatively, which he could on and off easily. And being a child, he needed something that was durable, waterproof, that can bear the rigors of his use. And then we have the extended ulnar gutter brace and the cock-up. This was a modified cock-up brace we made for neuromuscular patient at spasticity. This was a complete custom case we had. It's a sugar tongue brace. This was for a doctor in Devraj College in Kolar here. She had a lunate fracture. So we made her a sugar tongue brace with the provision for flexion and extension that could, at the elbow joint, that could give her added mobility. And right now we've partnered with MJ Naidu Super Specialty Hospital in Vijayawada, where they're using our splints as below elbow slabs post-operatively. So here you can see some of the cases where they're using the vola block brace, the ulnar gutter brace. So this brings us to our current catalog, which is the cock-up splint, stack splint, vola block, sugar tongue. Here you can see the provision for flexion extension, ulnar gutter and boutonniere. And as you can see, we primarily targeted upper limb splints because we're starting with the upper limb and we're slowly moving into lower limb splints as well. Currently, we've distributed over 500 splints, and we have our footprint in Karnataka, Andhra Pradesh, and slowly getting into Telangana as well. We've got very positive feedback from our clients. And I'll just briefly talk about the works that we have in progress in the field of splints. We have the dynamic splint. This is especially for neuromuscular cases. We're working on a very small, low form factor, easy to wear dynamic splint. Then we're working on above elbow and below knee orthopedic slabs, because we noticed that our below elbow splints like the ulnar gutter and vola block splints are being used as slabs for non-displaced fractures post-operatively. What we noticed is that, so as we're going around in Bangalore, we also realized that a lot of doctors, expressed a need for an alternative to POP that they'd like for their patients. So we started working on above elbow and below knee slabs as well. And we're also working on a OA brace and a medial offloading brace for osteoarthritic patients for the knees. This is our venture into the lower limb as well. And slowly we're getting into ankle foot orthosis as well. And as we grow as a company, our splint lineup will definitely increase. And that's our team. I'm Amartya, Satyam, and Dr. Vamsi is our orthopedic surgeon on board. So I also have a few models here that I'd like to show to elucidate the point. So this is how we have a prefab. This is what we've designed, what we 3D print, and this is the splint molded to my hand. And we've also created packages to make the process as simple as possible. So this is how our splints are packaged in envelopes, and then we just have a simple tray arrangement. So you can see the splint and the straps, and we're trying to make a system where what these splints actually are is semi-customizable. So how do you make this whole process as simple as possible so that the end user, that's the patient, gets the best product possible? And that's what we're trying to provide through these products right now. So yeah, that concludes our short presentation.
Any questions?
One question. So, what kind of a data input you need? Is it a clinical picture or is it a CT scan for us to send and get a proper splint from you?
Understood. So we actually have sizes. We have like small, medium, extra small, large for all the splints that are mentioned in our catalog. So you'll get these sizes. These sizes are based on anthropometric data, hand data, and you can select a size according to the patient size. But if you need something completely custom that's not in our product catalog, we'll need, depending on what splint it is, we need about 3 hand measurements in one picture. And within 48 hours, we'll deliver the splint to you, sir. So that's how we do distance splinting for purely custom cases.
But what kind of information you need? Is it a CT scan?
No, sir. Just basic measurements and a picture.
Basic measurements. Okay.
Yeah.
So
if
that
you
will
have
guide
a
us, right?
If you have a CT scan, we'll definitely use that. I mean, that will provide us with more information. But of course, in cases where scans haven't been taken, we just need basic measurements like palm width, this distance over here, and one picture should be good enough for us to begin.
Okay. So what you mean is for routine sizes and routine implants, we can use standard set of splints which you already have, right? But any special thing is needed, you are going to make it by taking measurements. Is that right?
Yes. Yes. Yes, absolutely.
Yeah. Thank you so much. So any questions to create labs?
Hey, Martya, can you hear me?
Yeah, we can hear you.
Yeah, hi, I'm Dr. Prashant from Mumbai, and interesting stuff. The thing which I wanted to ask is how much is going to charge to our patients, let's say for a below elbow splint, which is non-customized, and the customized one.
Right. So our below elbow splint, the lineup starts from 1,000 to 3,000. So like the thumb spiker would cost you would cost the patient 1,250, and the sugar tongue would cost the patient 3,000 rupees. So we're trying to keep our price within, marginally, if needed, marginally a little more expensive than POP slabs, but still affordable for patients.
You think that in the future, like when your company grows, the prices are going to come down?
Definitely. Yeah, we're working on that.
Got it. Okay, cool.
Thank you so much. So thank you, Amartya. We'll go ahead with the next part of the session. So for which most of the youngsters are already waiting for it, and the hall is full in kids now from the young orthopedic surgeons. Let us just move on. I would like to invite Dr. Rajeev to introduce our panelists and speakers for today's next symposium, which is on fellowship opportunities for young orthopedic surgeons. Over to you, Rajeev.
Good morning, everybody. We would first like to say that this is the first of its kind of a program, one of its kind of a program being held in India, where those who are currently doing a fellowship or who have just recently completed a fellowship abroad are going to talk to help those who are looking for a fellowship. And we would like to thank Twin Cities Orthopaedic Society especially for it, because Dr. Somashekhar Reddy and Dr. Srinivas Kasha sir readily agreed for this kind of a program which will help the young orthopedic surgeons, which is a very innovative and a very useful step on their behalf for the young orthopedic surgeons. What was the need for it? We felt there was a need for it because when I completed my post-graduation in Mumbai, there was very little information available for us as to how to go about in a structured way to apply for fellowships abroad, and what is the way we should apply for it, and what are the ratings, like which is a good one, which is a bad one, and what are the various stipend modalities that are available, and what is the cost of living, especially from if you do not have any connections with these people who are not based abroad. So that's the reason why we felt that we need somebody to guide us, and if you're not applying for a fellowship right now, then whenever you're applying for a fellowship at a later date, you can contact these people. The purpose of this is basically for those young orthopedic surgeons who are going to apply for a fellowship or who are planning to apply for a fellowship, so that they know what is happening abroad and they can apply to the best place possible in a systematic way, because our requirements differ. Each of us has different criteria. To that end, again, Twin Cities Orthopedic Society has taken a great initiative, and we hope that this will be an annual feature, and TCOS helps the young orthopedic surgeons progress in this way. Our first speaker for today is Dr. Supreet Bajwa, who is currently a fellow in Queensland, Australia in arthroplasty. He is a senior fellow at Sunshine Coastal Orthopedic Group in Queensland. And he's a very dynamic young orthopedic surgeon who's done a lot of research into fellowships, and he's one of the few who's getting paid as a fellow quite handsomely in Australia, and has been also asked to stay back as a consultant in Queensland. So we'll now move on to Dr. Supreet Bajwa's talk on how to apply for a fellowship in Australia and what to expect in as an Indian in an Australian fellowship.
I'd like to thank Twin City Orthopaedic Society for inviting me to have a chat with you all regarding fellowship opportunities in Australia. As a way of introduction, my name is Supreet Bajwa. I've done my D-Orth and DNB from PGI Miraj and then from Hinduja Hospital in Mumbai. I applied for a fellowship program in minimally invasive arthroplasty at the end of at the beginning of 2019, and I got that fellowship position in the middle of 2019 and pursued it by the end of 2019 and throughout 2020 in Sydney at Harbour City Orthopaedics to learn a procedure called Siddharth. I applied for a second fellowship in anterior hip replacements and kinematically aligned patient-specific knee replacement surgeries, and in 2021, and which I'm going to finish by the end of the year, and hopefully bring these skill sets back home. I applied to Australia because I found Australia to be a country where I was comfortable moving to. I've been coming to Australia every year. I have family ties in Australia. I liked the place. It was a diverse country. It had migrants from all over the world. Everybody was friendly. There was no racism. The transition into coming from India to another English-speaking country was easy for me, and I wanted to live a quality of life that I didn't enjoy in my residency program to the extent I wanted to. And thus Australia became an easy choice for me. When I came here, I found it difficult to settle into the working culture of Australia because we're so used to a structure that we're defined in India. Everything is very strict in terms of the code of conduct. It wasn't the same in Australia, and I found it difficult initially, but I started enjoying that eventually, and that process was really good and humbling for me. Things are done very differently in different parts of the world, and that was another learning experience. The way patients were being managed, the way patients' expectations were titrated, the way conversations went, the way surgeons conducted themselves, and it was good to learn from them regarding how their overall practice and the general direction of their practice was going. For me, the whole process of starting my application started in my final year of my residency program while I was in Mumbai. I started applying for positions in the beginning of 2019. I sent emails after emails, but I was rejected in most of them. So I had a word with Dr. Rajeev Reddy, who is the moderator of this meeting, but who was a senior and a dear senior who guided me in the application process. The process is very misunderstood because it is not a very structured application process. We're used to the structure. We're used to giving exams. We're used to, entering matching programs, but there was no structure to applying to orthopedic fellowships in Australia. First, what I did was I decided on a few subspecialties that I wanted to pursue, or I could consider pursuing: arthroplasty, sports medicine, anything to do with lower limb was something that I was always interested in. So I restricted myself to these sort of subspecialties. Then I calculated where I'm going to settle in life. And for me, it was going to be Mumbai or Pune. I had to be, and I have to acquire a different set of skills to survive in places which are highly competitive. I cannot learn the same posterior hip replacement, come back home and do them the way everybody else is doing them, because that would give me no traction and leverage. These are things that I really chased and decided upon at the time of my application. So I selected only those fellowships which I wanted to pursue for them to select me. Again, there's no right or wrong way, but when you apply, you have to give your fellowship supervisors what they expect of an applicant. Now, generally, a well-curated CV is at the top of it. Your referees are somewhere in the middle. But to me, the most important was your research acumen. And I had a discussion with two of my supervisors, and they said what helped me and what made me stand out in my application was the fact that I wrote my application eloquently. I wrote it well. It was well structured. So my application consisted of 4 things. My application letter, which was the first paragraph was an introduction of who I am. Second paragraph was about my training. Third paragraph was about my interest, and the fourth paragraph was how I would gain from the fellowship position. My CV was very structured, and the format is easily available on Google. So if you Google your CV, you'll understand. All you have to Google is CV Medical Officer Australia, and you'll get a format. You format it according to that application, and you're sorted on that front. Your referee reports matter in India when you're pursuing fellowships in India, because everybody knows each other. But when you start crossing international boundaries, only a select few names stand out. And yes, they do come in handy, but a lot of us will not have those big name referees. There's nothing to be dejected about, but put your referees on your CV, have at least 1 or 2 of them from the recent past 1 or 2 years. Research acumen, it's very important. I think it's consistently going to be spoken about by the other speakers as well. We have to have research on our application, because that's what really sets us apart from everybody else. I had 10 research papers on my CV before I applied for my fellowship position, and that's why I think I was selected. That's why my supervisor chose me, because he knew that I could add value to his practice, at least on that front. He did not look for somebody who had great surgical acumen, because it was his responsibility to give that to me, and I learned. So that was very important. So number 3 was my IELTS results. I gave my IELTS as a means to prove my intent of pursuing fellowships abroad. I got a good score, and I put it out there that I've done this as a first step of requirement, and this is what I have to give. I also attached my referee reports and all my research articles as a bundle in all of my applications, and I sent it across. Now, how I sent those emails and where I sent those emails was very important. So for Australia, because it's not a very structured program, you have 3 directories that you can directly pursue. Google AOA Fellowship Directory, Google AIMS Fellowship Directory, Google My Fellowships. You will get links to all available fellowships to international surgeons in Australia. That makes the process very easy. So start with these application portals. Other things that helped me and where I applied was I started networking with people who provided implants to these surgeons that I was working under in Mumbai. And there was a lot of contacts, and I could network and gain a lot out of connecting with these people. So if you Google Zimmer Fellowship Directory Australia, or Debut Fellowship Directory, or Medacta Fellowship Directory, you will also get links of surgeons who are associated with these companies, and these are more sponsored and structured fellowships, which helps your remuneration if it's a long-term fellowship. I timed my application in my last year of residency, and I think that's one of the better times, because you're exposed to all subspecialties during your training, and you go through the hoops and you understand what your interests and where your interests lie. So if you're in your first year listening to this talk, don't be worried, get onto your research. If you're in your second year, get onto your research. When you're in your final year, you will have a ballpark idea of where you want to be and the reasons for pursuing fellowship. After my application, I got a call from my supervisor, Dr. Sol Qureshi, who wanted to have a video interview with me. Again, it was a very informal interview, and that's how people interact out here. There were 5 people interviewing me, asking me about my reasons to be there, where I see myself in 10 years, what is going to be my scope of practice, what he expects me to gain out of the fellowship, what the fellowship would provide to me. General chit chat, but conversations on these lines. What followed thereby was an approval letter and a very long process of applying for a lot of paperwork. The paperwork to Australia is extensive. It took me close to a year for all my documentation to be finished, but the silver lining in all of this was no matter what fellowship you pursue in Australia, you're going to be provided with a fellowship coordinator. So he's responsible for to get your scores, to your visas, to your good standing certificates from the country that you're from, to getting your AMC registration, to get your APRA registration, to get your RACS registration. All the documentation that's required will be done by that person. It's not your headache. So it's nothing for you to be concerned about. You need to have a clear idea of what you expect from your fellowship. And for me, it was very important that I got a few things that I expected from my fellowship. I'd done a lot of things in my residency program, and I'd done my residency program in a private hospital, but also a public hospital because I had my degrees with me, my diploma and my DNB. So for me, it was my reason for pursuing fellowships in Australia was a different skill set. I wanted to be distinct, and that was my reason. I was not crazy about cutting. However, cutting and getting exposure to surgical acumen and developing it in Australia is very dependent on your rapport with your surgeon. If he trusts you, which it took a couple of months for my chief surgeon to trust me, I was doing all his public cases in 4 different public hospitals in Sydney for him. And, you know, that's how generally things work in the public setup. What I also wanted to learn was the ins and outs of how the practice, you know, how practice in different parts of the world is run, and just the way you would conduct yourself, just the supplies, the interactions, the way you deal with people, the marketing side of practice. And I started noticing all these things and noting all of them down and making my own protocols. The implants I would use, the decision making, you have to understand that this is not going to be an extension of your residency, but it has to be the beginning of your independent clinical judgment. Once you realize that, it becomes easy to gain more from this experience. Again, if you're not confident in your skill set, you will be held back on the surgical side of things. So you have to be mentally prepared that this is a different system. You come from a different system. You should not be expecting cutting on a daily basis. It will not happen until you prove yourself into the system. So once you do, sky's the limit. You get to do everything that you have to. The other things that you really deal with on a day-to-day basis is lack of association with home comforts. But it may also work in another way. When you live your life in a different country from a different perspective and experience life broadly above and beyond orthopedics, your blinders are taken off, and you know, you start enjoying it a little too much, which is my stage at the moment. I really like the quality of life that Australia's given me, and I couldn't be more grateful for it. What worked in my favor in my second year and my second application was the fact that COVID had stopped all incoming international fellows. So I got to work with my current fellowship, which is the Sunshine Coast Orthopaedic Group, which has multiple surgeons doing exemplary work. David Rodda, Frank Connon, and Shane Blackmore are people I'm associated with, and I work with them and I'm operating with them on a daily basis, and I've acquired tremendous confidence in my skill set. I've started doing anterior hip replacements, which are not done routinely in India, and to me, that was a big gain of this fellowship. And not just that, but the fact that this practice gave me a lot of support emotionally, mentally, and helped me adjust into my surroundings. And I couldn't be more grateful to be here with them. COVID helped me to get that position because I think this is a very valuable position. How it changes in 2022, I don't think travel is going to resume normally in 2022. We may have restrictions. So we have to be reasonable. When you apply for fellowships, say this year, you apply for 2023 and 24, and you have a reasonable shot of getting that position in when, hopefully when things normalize. Also the fact that we are competing with European fellows and fellows whose training programs are accepted in Australia, which means their APRA or RACS registration in this country is accepted, which means they are close to being independent surgeons and we are supervised surgeons. So they are preferred over us, but it's not a rule. It's something that I've noticed. It's definitely not a rule and nothing that should be limiting you in applying for positions. All fellowships in Australia above 6 months are sponsored fellowships. They are paid for. The minimum that I've had and I've read and I've gathered from all the other fellows in Australia is that we're paid anywhere between 60,000 to 120,000 Australian dollars a year. It's enough to live comfortably, but there is an initial cost associated with all your documentation. So if you're not from a very privileged financial backing, you want to save some money before accepting a position. Anywhere between 5 to 10 lakhs in getting your licensing out here, your travels, your quarantine, your rents, your car. These are expenses that add up, and these are things that you have to be prepared for before taking up any international fellowship. As far as long-term prospects that I was always considering, and that's really something that all of us think about. Australia is not the most conducive place for us and Indian trained surgeons to move to. They do not recognize our training program, and that's a blanket rule. So any orthopedic surgeon who I've seen moving to Australia in the past 10 to 15 years has had to repeat their program. Remember that getting into a training program in a different country with a system that you're not used to is not easy. It takes you a couple of years to understand the hoops of it, a couple of years to become competent, and then you enter the training program if you're at that level. It's a commitment of at least 10 years, and in my opinion, it's not worth the investment. But if it's what you'd want to consider, sure. So in summary, just define your reasons, see why you want to be in Australia, select a few subspecialties, and that you want to stick to for the rest of your life. Rejections are a part of applications. I have been rejected more times than been accepted. I should mention that when you send your applications, you should send them individually to each email and not as a blanket or multiple applications and CCing surgeons in them. They all go into junk folders and it does not reach their practice. So please take the effort to individually apply. That's something that I learned even from my supervisor, who said that these applications don't reach me. My application reached him possibly because it was a single application. Remember the reasons for your applications. Remember the reasons for you to pursue fellowship. It should not be imposed by the corporate culture that we have in India. It should not be imposed by your peers. It should not be imposed by the documentary requirements of becoming a consultant in India. It should be imposed by your reasons to develop your skills. You find your reasons, stick to them, but don't let people around you dictate what you want to do in your fellowship applications or your fellowship training. Please remember about sending individual emails, being very particular about your grammar when you represent yourself virtually, when you send emails, your CV, your application letter, and developed research acumen. I'm happy to help anybody who wants to reach out to me on any of these links that I've attached. I know that I haven't gone into the depths of my experience, but to start off with, I've given whatever I could help, and I'm happy to help further with direct guidance to anybody who wants to reach out to me on any of these platforms. I wish you the best, and web peers, we're friends, and I'm happy to help anyone who intends to be here in the long run, in the interim.
Good morning. My name is Dr. Siddharth. I'm a spinal consultant at Queen's Medical Center, Nottingham. At the outset, I would like to thank Dr. Rajeev, Dr. Kasha, and Dr. Reddy for this invitation to talk today. I'll briefly discuss my process that I went through in applying for a fellowship in the UK, and I hope that you find it useful. Why did I choose the UK? Now, essentially, UK is based on the NHS for its healthcare, which is National Health System, which caters to the whole country, and it's spread out throughout the whole nation. And by extrapolation, we would understand that the patient base that we would cater to is huge. At the same time, the wide network of the NHS would also give us an extensive availability of different training positions and vacancies, which potential international graduates like us can apply to. Secondly, it is more of a protocol-driven healthcare where the decisions and the protocols are based on the evidence-based medicine, which gives a particular form of unanimity towards the treatment goals and treatment protocols that are followed. Along with the evidence-based medicine, there is an element of multidisciplinary teamwork where we work along with other teams like the physios, the orthotics, the occupational therapists, the nursing team, all of them who combine towards a more holistic approach towards the patient's healthcare. Because of the amount of resources, we have the all technological gadgets, like for a spine surgeon like myself, we have the O-arm, the endoscope, the navigation, all of which are skills that we intend to gain from a fellowship, because essentially the purpose of the fellowship is to become better versions of the surgeons that we already are, and to get those extra set of skills, that finesse and that refinement that we want to achieve in becoming better surgeons and better clinicians. So all of this combined gives us an academic push towards deciding where we want to do a fellowship in. In addition to the academic bit, there were other purposes as well to coming to the UK, like a good work-life balance, opportunities to travel, to explore new cuisines, to meet new people, and to embark on monetary goals for our future, all of which should be accounted for in terms of planning where you would want to do your fellowship at. Once you've made a decision that you want to come to the UK for a fellowship, then comes the question, how do we do it? And that's usually a very confusing question for many. Now, essentially, to clarify that question, there are two pathways to coming as a fellow in the UK. One is an MRCS pathway and one is a MTI, or the Medical Training Initiative. For the MRCS pathway, the path begins with giving the MRCS, steps 1 and 2. Once you give your step 2, then you apply for your GMC registration. GMC is the license that you need to practice in the UK. Once you've got the GMC registration after MRCS, Then you apply for your fellowship jobs, get through the interviews, get selected, and start your fellowship. That's the usual course. The medical training initiative works a bit differently. Here, the difference is how you get your GMC registration. So here you actually begin with applying for a job, get an interview, get it selected. Once you've gotten selected, if that program supports MTI candidates, then you contact the Academy of Medical Royal Colleges. So essentially issue a certificate under the International Medical Graduate Sponsorship Scheme, which gives you a letter to submit to the GMC, who then gives you a GMC registration without MRCS. So once you've gotten that, then you essentially already have a job, so you can just start your fellowship thereafter. So both the approaches are different in terms of how you are going to be applying for the fellowship. Some fellowship must-haves, which I looked at when, or I kept in mind, or which I would advise to keep in mind when you select a fellowship program. One, it should be a specialized center. You should have a variety of consultants, multidisciplinary teams, something which will allow you to refine yourselves, good volume and good exposure towards patients and different techniques and surgeries that you would want to learn. Niche specialties like for spinal surgery, like endoscopy, navigation, craniocervical surgeries, complex pediatric surgeries. Depends on what your interests are. So you should know what you want from the fellowship and look for that in the fellowship program if it provides that to you. And lastly, and most importantly, adequate duration. Optimum duration of the fellowship is a must to extract the maximum benefit from your fellowship years. On the other hand, fellow qualities in you as a fellow or as a potential fellow who wishes to apply. Dedication, commitment to giving all that you have towards the fellowship program, being a team player because you're going to be working with different teams. Each team looks after a different part of the healthcare of the patient, and together you will be a holistic approach towards the patient care. So you should be a team player, being open to suggestions, reviews from different members of the healthcare team. Most importantly, research interest, and this cannot be emphasized enough by all the panelists, that you should have a good academic inclination, which can be reflected from your CV, from the things that you've done in the past, including publications, presentations, conferences, cadaveric courses, CMEs. All of those go on to your CV to reflect what level of academic inclination or academic interest you carry along when you apply for a fellowship program. That is something that every interviewer would look at. Lastly, good referees, because once you've got through an interview, your referees would be like your light post who would shine the light on you. If you want an interviewer to know the finer aspects of your qualities, then your referees and your references would be of key value in that regard. So all of this is quite important when you decide to apply for a fellowship program. Going ahead with the application itself, all applications in the UK are centralized by law to be on a public platform. So you go on to various websites called the NHS Jobs, the Track Jobs, and NHS Scotland Jobs, where every vacancy would be advertised. Once you find a vacancy which you are interested in, you apply for the job on the website. They have a facility called email alerts, which I found is quite useful. You select the specialty you are interested in and subscribe for the email alerts. Every single time a new vacancy or new job comes up, you'll get an email that helps you keep a track of every application or every vacancy that comes live for you to be able to apply and not miss out. Lastly, persistence is key. Don't get disheartened if you apply for a program and don't get selected, because the demand is high and everybody is as qualified as you. So to be able to stand out, the best way is to keep applying to multiple programs to increase your chances of being selected. Ideal duration. For me personally, I would say at least a year, and on a very bright side, 2 years, it would be an ideal duration for a fellowship. That's purely because what you go through once you get selected for a fellowship is a process. You come, you settle in, not just from a work perspective, but primarily you start settling into the weather, the cold, the process of preparing your own food, washing your own dishes, adjusting to the lifestyle. Then comes the process of adapting to the workplace. It's a different system. It's a different set of people, different workplace systems technologically which are involved. All of that takes time getting used to. Then you move on to team building, where you start forming a bond with your mentor. You start getting to know different people in the department, the different consultants. You find one mentor, one consultant you are comfortable with, and who is comfortable with you, and who then would then have adequate confidence on you to give you that hands-on learning and skills that you have come here to develop. So it is a process that you go through, and that is something which needs investment of time. And I feel at least a year, and on a very good note, up to 2 years would be ideal to go through that process. Stipend wise, it tends to be adequate. You get something around 32,000 to 45,000 base salary in a year, plus you get an on-call supplement. Deducting the insurances, you get something around 3,000 to 4,000 per month by hand. Cost of living tends to be reasonable. It depends, of course, on how you live, but on an average, the cost of living tends to be anywhere around 1,500, 2,000 per month for a decent living for a family in this country. Of course, if you're living in more expensive cities like London, the cost tends to be higher. But you are allowed to do additional work, like locum work on weekends, on your free days, if you wish to have intentions to earn more. So that gives you a certain element of financial security as well when you take up a fellowship program. Lastly, my experience here, I worked in Nottingham, which is the busiest center in the UK as far as trauma and spine is concerned. Having an exposure to everything from the occiput to pelvis was purely possible because we had a team of 8 super specialized consultants, each catering to a different subspecialty of spine. That just gave me a better insight into what I wanted for myself, or how I wanted to evolve in terms of becoming a better spine surgeon. Multidisciplinary teams were a game changer. They essentially just open your eyes towards the different aspects of patient care, which we may not necessarily be trained or may not have been necessarily exposed to. And that essentially is quite key to optimizing the healthcare of every patient that we look forward to. The research unit was a boon. It's a completely dynamic aspect where you have research assistants and research analysts who do the core work which goes into an adequate research project, which helps you focus on the more important aspects of research to produce quality data, to produce quality papers and presentations at conferences, meetings, and publish in journals of repute. Lastly, and this cannot be highlighted enough, having good camaraderie with your colleagues was the epitome of the time you spend as a fellow. And for myself personally, I was blessed to have an excellent team of colleague fellows, consultants, and every person working in the department who just made the experience completely enriching. So yeah, that in short is my experience of how to go about a fellowship in the UK. I'd be happy to take any questions when we come to the question time. Thank you.
Good morning, Twin Cities Orthopaedic Society. I'm honored to be here presenting on orthopedic fellowships for United States and South Korea. I'm Dr. Prashant Meshram. I'm not new to Hyderabad and Sikandrabad. I visited there in the past. I really love the Hyderabadi biryani, the Charminar, the Good morning, Twin Cities Orthopaedic Society. I'm honored to be here presenting on orthopedic fellowships for United States and South Korea. I'm Dr. Prashant Meshram. I'm not new to Hyderabad and Sikandrabad. I visited there in the past. I really love the Hyderabadi biryani, the Charminar, the Ramaj Film City, and of course the famous movie Angreez. I don't have any financial disclosures for this talk. I'm a member of American Shoulder and Elbow Society and Indian Arthroscopic Society. My talk is really based on the articles I've written in the past on this topic and my fellowships at Johns Hopkins USA and South Korea at Seoul National University and TK Orthopedic Surgery. This talk is really for orthopedic residents and senior registrars who are looking for a short route to get overseas fellowships and do not want to appear for any exams. I'll be talking in three broad terms. First is node guidelines for getting fellowships, how to get them in South Korea, how to get them in USA. The node guidelines I wrote first about in the Bombay Orthopaedic Society column, the link for which is available on my Instagram. I've created this fellowship highlight, which has stories one by one, all my talks and all my articles about how to get fellowships and different aspects of it. So node guidelines is really networking, exams, research, and diligence. Those are the four key basic steps which are to be followed if you want to get a fellowship overseas. Networking really means interacting with the peers to develop professional and social contacts. What you got to do is make local mentors who will help you to identify and get fellowships outside with overseas mentors. These mentors really form a support system for your life, as you can need in the future for your career development, in terms of your job opportunities, in terms of research opportunities. They form a bond for the whole life. Jack Ma, in his very famous interview with the World Economic Forum, said that 20 to 30 or 35 years of age, which is most of the audience, I believe, the target really should be to follow the good boss. So who is actually, in fact, would be your ideal local mentor who can help you get an overseas fellowship? He should be someone who practices your own specialty, should be academically active, and follows a lot of research, publishes a lot of papers, someone who is fellowship trained overseas, someone who has an international network like a president of orthopedic societies. Now, how do we identify overseas mentor? The first direct contact would be if your local mentors can recommend you for an overseas fellowship. That is the best way to get a fellowship. Another way is if you can meet all these overseas mentors who come for to give talks in international meetings and conferences in India. You can go up to them and you can talk to them about giving you opportunity, and you can ask them that I'll send you an email, I'll send you my CV, you can consider it. Finally, through PubMed. How do we identify mentors for your overseas fellowship through PubMed? Is you just open PubMed, type your specialty, shoulder surgery. You would get the recent articles published. You see who is publishing the most. That guy is probably more likely to have research funding, and he can fund your fellowship overseas. If you want to find my mentor, whom I did by the fellowship, you don't even have to ask me. Go for any of the articles which have recently been published, and you see the last mentor, the last author is typically the senior author, and he's the mentor. And if you go to the full text link of this particular article, you just need PubMed, and that's it. If you go to the full text link, there's a small icon here which is which is like a letter. If you click there, that is bam, it will give you the email address of my particular mentor. You can apply to him. Rigorous work on your email application while applying for overseas fellowship. They judge you. They don't know you personally. These overseas mentors judge you based on the quality of your email. It should be described in 3 paragraphs. First is who are you? Who recommended this fellowship for you? Why this particular fellowship? And why should they choose you? What you bring to the table? I have uploaded the format for the email, how to write the CVs, how the LOR should be on my Instagram page. It's also available on my Facebook page as a highlight, story highlight. If someone's looking for clinical fellowships in the United States, you must do USMLE exam. Residency is optional, but USMLE is must. Residency is recommended for those who want to settle down in the United States. I did a research fellowship in the US and did not need to give USMLE. For South Korea, it's very difficult to get a license because of baseline MBBS degree is not recognized in South Korea. None of the Indian institutes are recognized, or universities are recognized in South Korea. The mantra for paid fellowships without giving any exams is research publications and plus networking. Research even like surgery, it is like a skill set. The more you publish, the more you get better at it. The more support system you have, easier it gets. Residents should really try to publish and present their thesis because they're allowed to make mistakes. They have more time to publish, and it's really good ahead. If they publish something in their residency, they are more likely to publish elsewhere, more in life after their residency, and more likely to get a very good paid fellowship at a very good institute. Also prefer quality over quantity when you're publishing papers. You've got to be the first author. You've got to publish in PubMed Index journals with impact factor. These journals have also the list of these journals where you should try to publish is also included on my Instagram page. Third, fourth most important thing about NERD guidelines is diligence. Diligence is doing a job efficiently and taking care of little details. The attitude towards your mentors so that they can give you recommendation for fellowship should be of mutual growth. You should work hard with diligence and humility. This kind of turns into respect and trust, and you get recommendations for fellowships abroad. My local mentors have really called up, and they have sent personal emails requesting the overseas mentor to give me the fellowship, and that really makes a lot of difference. Let's see how we can apply the NERD guidelines and how we can go about fellowships in South Korea. So South Korean fellowships basically are their joint specific practice in South Korea. The surgeons will be knee surgeons, shoulder surgeons, spine, tumor. There are no arthroplasty, arthroscopy surgeons. They would take one joint and do everything. So be prepared for that. Second is most of them will allow you to scrub in, but you must confirm this beforehand. There's no hands-on surgeries. No one will give you hands-on surgery overseas unless you have a clinical fellow, unless you have a medical license to practice there. You'll get a lot of sawbone workshops. You'll get to publish papers. It will be a stepping stone if you want to further go down the road of US research fellowships, which I did. Your application should be done as soon as possible. If you want to go to South Korea, I would do it in last year of my residency, because the waiting period for any good fellowship which is paid is at least 2 to 3 years. Well, what you really need is an updated CV. You need a letter of recommendations from previous fellows, and also you need research papers. I have for my fellows, for my fellowship mentors, their contact numbers, their contact emails have been uploaded on my Instagram page. Do they pay you money for fellowships? Oh yes. Most of the fellows which I have seen who went to South Korea for an orthopedic fellowship were paid somewhere in between 70,000 to 1.2 lakhs INR per month, and half of which, or I would say 40,000 to 50,000 of them will go in expenses. Will food and language be an issue in South Korea? Most of the people speak English, and basic Korean can be learned in YouTube. I joined a weekend class because I was there for a very long time. So I needed more grasp of the local language to understand and interact with the colleagues. There are limited options for vegetarians and food, but you can survive. I have known people who survived there for a year, and it's really not that difficult. What about the United States? The dictum is to apply as soon as possible. The email sources would be your previous fellows who are local mentors. OrthoGate is a really good website. The link for which is on my Instagram. Go there at least for 1 year for a research fellowship. It's really worth it. The rule for how to get a US research fellowship is, I cannot sum it up in a better way than my mentor from Johns Hopkins, Dr. Edward McFarland. 90% of life is just showing up. Just send that email. Just don't think about it. Keep sending emails. Throw everything at the wall and see what sticks. And it does stick. This limited paid fund research fund fellowships in United States. What you really need is strong research background and recommendations. So you probably need to work for 1 or 2 or 3 years on research after your residency and during your residency in order to get enough number of publications to be able to qualify for your US research fellowships. They pay you around 3.2 lakhs per month in terms of Indian money, half of which will go in expenses, rest you can save. What US research fellowships really offer is an unmatched research experience. They have resources much better than most of the countries in the world. You'll get numerous pubs and presentations, boost your CV, international recognition. I could never imagine becoming a member of American Shoulder and Elbow Society, but only because of my research fellowship at Johns Hopkins it was possible. You also do get to perform, you get to observe a lot of surgeries. You also get to attend top-notch conference meetings. You get to present in them. Of course, you make friends, and you make your colleagues would be those in the future. They would be the leaders in orthopedics in the world, and it would be good to have a network with them because that will help you further down in your career in the future.
For those who are looking for US clinical fellowships, you must do USMLE. For USMLE exams, the time to start preparation is second year of residency. Once you're done with your fellowship, go for research fellowship for 2 to 3 years in the United States. Meanwhile, you can prepare your steps. What you need for a fellowship is to get a clinical fellowship is letter of recommendations from United States surgeons, about 20 odd publications in reputed journals. And you can either do a 4 to 5 years of residency if you want to settle down there and get a job there in the future. But if you want to come back to India, I would recommend directly applying for a fellowship after you clear your USMLE. You need perseverance, it takes time, it's worth it. In summary of the talk, the way really is to network, is to try to get some exams, do your research and be diligent. South Korea is an easier option. You get very well balanced choice. You get your research, you get your surgical experience, you get to publish papers. US research fellowships are tougher to get, but they're definitely worth it. All of this material is explained in detail on my Instagram page, on all the links in this fellowship highlight. They're also on my Facebook page. I would leave you with the words of my mentor, Dr. TK Kim from South Korea, whom is one of the greatest person I know. Unless you spread your wings, you will have no idea how far you can fly. Thanks for having me.
Hi, good morning, everyone. This is Dr. Mahesh, Jawhar. I'm an orthopedic surgeon from Mumbai. I did my fellowship in shoulder and elbow surgery, and I would like to thank the organizing committee from TCOS for giving me an opportunity to I did my fellowship from this institute called Hospital Services. It's in Catholic in Emilia-Romagna province in Italy. It's a state-funded institute, and my fellowship was in shoulder and elbow arthroplasty and scopy. So my program directors were Dr. Paolo Palladini and Dr. Giuseppe Porcellini. So it lasted for 6 months from Jan to July 2019. The number of doctors were 2. I chose Italy because I had heard about this institute from the previous fellows who also happened to be my senior colleagues. They said it had a good workload and a good hands-on experience. Italy as such is a friendly country. The cost of stay in the fellowship is much lesser than other European countries and US or any other countries as well. The visa process is relatively easier for Italy as compared to the other European countries. So the process goes like this. I had sent an email to the program director describing about my interest in shoulder surgery and the people I'd worked with who were his previous fellows. He asked me to select a fellowship duration somewhere between 15 days to 6 months. Any stay about 90 days in European Union needs a long-term visa. So the only way through this is a study visa. Now, the application for a study visa could be tedious. So we start with translation of our documents from English to Italian and send these documents to the embassy. They do a process called declaration of value. It takes about 3 months of processing time. You also need to submit your proof of stay. If you're planning for a shorter duration, lesser than 90 days, so all you need is a tourist visa with an invitation letter from the institute, pre-booked flights, the stay, all that. The environment in Italy and the institute was overall friendly. So I wasn't treated anywhere differently because I was from India or I didn't speak Italian or something. Though I was the only English-speaking person in the town, probably. Everyone could manage to speak somewhat of broken English, I would say. Indians are welcome, unlike I don't know if anyone had a different experience elsewhere else, but there was absolutely no problem for me. They expect you to be knowledgeable, and this is a question that everyone does ask me: do they allow me to scrub it? So yes, for me, right from the day one, from the first place, my boss made it pretty clear. We had a team of 8 shoulder surgeons, and everyone did make a honest attempt to give hands-on or teach or whatever skill they knew. About the experience, we worked from Monday to Friday. Our caseload was pretty good. We used to do about 8 to 14 surgeries every day. That included starting the day with about 2 or 3 arthroplasties. Most of them were reverse shoulders. We did have some total shoulders, total elbows. Tendon transfers, we did have pec minor, latissimus dorsi, a lot of letargy. And in arthroscopies, we did a lot of vertical cuff tears, bunker trip repairs, and a lot of elbow arthroscopies, pediatric elbow arthroscopies as well. We did have trauma cases, usually about complex proximal hemorrhages, scapular fractures, coracoid fractures, distal clavicle fractures. As responsibilities as a fellow, you don't have the language clearance. You need to be at least B2, C1 in Italian to be legally employed in Italy. So your fellowship is more of an observership on paper, but they do allow you to scrub in and give you some hands-on. There is minimal interaction with patients because of the language barrier. It's more of a surgical fellowship. You are free to attend the OPD, but it's very difficult to grasp the patient-doctor conversation. There are no ward duties, no emergency duties. All you have to do is assist or occasionally perform some surgery. Hands-on, it depends a lot on your pre-existing skill in arthroscopy, especially, and your approval process. So I had no experience. I had just assisted arthroscopies, not performed any on my own. And it took me a while to get the triangulation and everything. So maybe they took about a month or something to start giving me cases. And about the Rappo, it takes about a month or a half to actually, for them to recognize that you exist. So if you're planning for a fellowship duration, you can plan accordingly. About the pros, we had a very good exposure. Almost everything in shoulder and elbow surgery, like managing simple lateral epicondylitis to total and reverse shoulders. About the hands-on, a lot of people are, I think, concerned about this aspect. Being a foreign fellowship, do you really get it? Yes, we do. I started getting portals in the beginning, then subacromial decompressions, then taking bites, taking knots. So these were gradual, and over the 6 months of time, I got about 60 to 65 cases of hands-on, like partially. Pretty much confident at the end of the fellowship to do at least a simple soft tear on my own, which is, I think, pretty quick for 6 months. We had a very good volume of cases. I got about 600 plus over the 6 months. I did stay up 15 days extra and had a lot of more cases. And Dr. Giuseppe Porcellini is one of the senior most orthopedic shoulder surgeons in Italy. He started this institute in '98, and he's well known. A lot of publications for him. Coming to publications, I had the opportunity to be a part of at least 7 publications, 6 of which are ongoing. We had 1 published, presentations as well. Since Indian fellows are good with their English speaking skills, they make use of this and help you. They expect you to help them out with their manuscript editing or presentations or whatever. So the environment overall is extremely pleasant. Okay, it's very comfortable. The only issue that I could face was the language. So coming to the points, unlike our institutes here, they didn't have an academic discussion as such ever. It's not a teaching institute, it's not a university hospital. So I didn't expect this to happen either. Though there were some courses or seminars organized, but most of them were in Italian, difficult to follow these discussions. A major issue that I would like to address is the problems while assessing. So most of the consultants speak Italian, not so good in English. So the commands or the conversation between surgeries is difficult to follow. It's difficult to grasp. So you can end up making some mistakes that might not be so pleasant. So that is one thing you can take note of if you are planning to do a fellowship in a non-English speaking country. The mentors are obviously eager to teach, okay, but the only medium is English for them to communicate, which they are not good at. So I could feel that they did restrict themselves about speaking because they didn't want to expose their poor English speaking skills. So that is a negative point in this country. I'll come to a stipend later. Exposure to OPD was pretty limited because, again, of the language issues. So if you're planning to develop clinical examination skills, and all that might have a setback from this case. The duration for my fellowship was about 6 months, but I would say the ideal duration is about 1 year. You get to see more cases, be more confident, because getting a lot of shoulder cases right from the beginning of your practice in India is difficult. So it's better you spend as much as time possible over there. You do have enough freedom to choose your own duration of fellowship, but I would say 6 months is the ideal time. Considering the cost and everything, the visa issues and everything, I think 6 months is ideal. As I said before, yes, it does take about 2 months to build a rapport with the bosses. The close rapport, I would say. Stipend was being issued for the previous batch of, until the previous batch of fellows. It was about 800 or 1,000 euros per month. Discontinued from my batch, it was pretty unfortunate for me. About the cost, it costed me about 5 to 5.2 lakhs for the entire 6 months. It included the travel, the stay, the food, everything, the sightseeing as well. So if you're planning to stay or arrange your own stay, you can book an Airbnb. They do provide you with institute accommodation, but you have to pay for it, and it is more expensive. You can, if you're lucky, you can find a cheap apartment by the beach for like 400 euros. But it depends on the time of the year. Catolica is like the Goa of Italy. So summers are very expensive. So it's better to plan your fellowship around Jan to July. It's one of the colder months. So that could be cheap. Transportation is expensive. Buses or any other cabs are very expensive. So it's better to walk down or cycle. Food, vegetarians would struggle, I would say. I was a vegetarian, so the options for eating out are limited. If you still plan to eat out, it does cost about 15 to 20 euros in a good, decent restaurant. Cheap restaurants like kebab diners and all cost about 10 to 15 euros. But still, you end up spending about 40 euros a day if you plan to eat outside, which is very expensive. Indian groceries are hard to find. Pasta is easier. So I would recommend you take everything from India. Medicines as well. So for the spouse, I think you can come for a maximum of 90 days tourist visa. If you're planning for a long-term visa for a year or something, it is possible only after you reach Italy and start the process all over again for your wife. So coming to the end, the overall experience was very good. Had great hands-on skill. An additional skill that I learned was musculoskeletal ultrasound imaging that I learned from a local Italian fellow, kind enough to teach me that, which I still use in my practice. The physiotherapy protocols are different. I'm still in contact with my mentors. I discuss every case with them, every shoulder case with them, and they provide with me the inputs and all that. I did a lot of reading prior to my fellowship, but I feel I should have read more. So it's better you plan your fellowship way much in advance. Start reading right away. And it doesn't hurt to learn some Italian before going. It's a very easy language to make your stay and your fellowship much more comfortable. Okay, thank you.
Thank you, Dr. Mahesh. We would now like to hear from two mentors, two people who are training a lot of fellows in the country. The first one is Dr. Parampreet Singh Nagpal, who's an arthroplasty trained surgeon, who's now training young arthroplasty surgeons in Punjab. He is the chief arthroplasty surgeon at Nagpal Specialty Hospital in Punjab.
Can I just suggest something, please? I just can we just pause this for a second? Can you just play? Is the audio coming clearly for this video?
I would also like to thank Rajeev as well as.
Yeah, so could you just pause once? Just a suggestion: if you can stop screen sharing for a second, whoever is the host, we can see if we can get to the bottom of the audio issue. We can stop screen sharing for a second. And then when you're sharing the screen again, just make sure that the share audio is selected when you're sharing the screen again. I think you're getting the audio through the mic and not through the actual sharing. Now, when you're sharing the screen again, just make sure that the share audio is selected. Maybe now you can try.
Sir, headphones on, sir. Microphone audio, sir.
Yeah, that's what I'm saying. You're getting through microphone audio. We don't want microphone audio. మీరు షేర్ స్క్రీన్ పెట్టేటప్పుడు కింద లెఫ్ట్ సైడ్ లో ఒక ఆప్షన్ ఉంటుంది షేర్ ఆడియో ఫ్రమ్ ద ప్రెజెంటేషన్ అని చెప్పేసి అది మీరు క్లిక్ చేయాలి మళ్ళీ స్టాప్ షేరింగ్ స్క్రీన్ మీరు ఇప్పుడు షేర్ చేసేటప్పుడు కింద లెఫ్ట్ సైడ్ లో ఆప్షన్ వస్తుంది మీకు షేర్ ఆడియో ఫ్రమ్ ప్రెజెంటేషన్ దొరికిందా
Share sound, yes.
Yeah, please click on that and then now you will get the audio from the actual file. Till now you've been sharing it through the mic.
Hello friends, I'll firstly like to thank Rajeev Reddy as well as the Twin City Orthopaedic Society for inviting me to give this talk. Today I'll be speaking on a mentor's mindset. I've been running a fellowship program in my hospital since 2019. I'll firstly like to tell you about my setup. We are basically a joint replacement center. We do both hip and knee replacements, both primary and revision. On average, we do around 50 to 60 joint replacements in a month. And there's occasionally some trauma procedures as well as some arthroscopy procedures which are done. We have two types of fellowships in our hospital. One is the long term, which is running from 6 to 12 months, and we pay a stipend to the fellow. And there is a short term fellowship, which lasts for 2 to 4 weeks. We try our best to keep the number of fellows down to a minimum of 2, one long term or one short term at the moment. When I was fellow, I did my fellowships from Germany, Netherlands, Belgium. There was always a problem in understanding the language. There was a language bar. Whatever doubts were there which were asked, they were replied well, but the on-paper discussions which the surgeons do while performing surgeries, I used to miss out on them. And that was one of the key factors need to be passed on, which are very important for the understanding, should be passed on to the young surgeons. There was a lack of one relation with the mentor because there were multiple surgeons and there were many fellows. So there was not like a bonding was there. The holistic approach was not there in a fellowship. And they only imparted all the surgical techniques, but the pre-op workups, the post-op management, the protocols, they were not passed on. So I wanted to give some a holistic experience to the fellow so that once he goes out, he is fully prepared to for his patient. Because of these tough times, we used to work hard and get the best out of the time we had at the fellowships. Expectations of a mentor, well, we all expect that we get a fellow who works like a PG and doesn't ask for a stipend. He works 24/7 and also throws you parties every weekend. So on a realistic side, the basic qualities you expect from a fellow are he should be willing to learn. So you cannot work with a person who is having a deaf ear, who doesn't want to listen to you, who is just there just to be there. We want somebody who is actually keen to learn and pays attention to what you are telling him. He has to be sincere. He also needs to be accountable. I hold accountability very high. He should be doing his duties without excuses. He needs to be accountable for his actions. Punctuality is very essential. We as surgeons don't like delays. We want us OTs to run fast, the shifting procedures to be fast. He has to be very truthful and trustworthy. If any mistake has happened, he should be upfront and accepting it. He has to be hardworking, and the feedback is very important. If some feedback is given to him, he should take it positively and also put it to correction. Why we need a fellow? Why I need a fellow? Well, there is a will in me that I should pass on some essential knowledge and skills. And also the private practice is actually very demanding and very taxing in the long run. Seeing outpatients, the follow-ups, daily doing surgeries, attending emergencies at orders, daily rounds, dressings, post-op case managements and their complications. So it can be hell lot of things to do for a single person. So a fellow can give you a very good helping hand. It's very important for a fellow before joining to be transparent about what he expects from his fellowship, and he also should be made aware what are his roles and responsibilities that he needs to do during the fellowship. He must also inquire regarding what opportunities he might get during the fellowship. So what we expect a fellow to perform, he should perform basic trauma surgeries. He should be doing morning and evening rounds. And we expect him to pick the basic complications, like if there is something like early signs of pulmonary embolism, or there is acute renal failure setting in, low output is there, patient is running fever, there are some signs of infection. So he has to be very aware about these things and pick up small signs which can later on get complicated. He has to attend all the emergencies. He should be assisting all the surgeries without looking at the working hours or looking at whether he's had food or not. Because surgeries, we all know that is our first love, so we cannot think of other things before surgeries. So he has to be very courteous to the patients, because we know sometimes patients can be demanding. They keep asking silly questions, but we have to keep answering them, and that too politely. And he should also be commanding in the operation theater, because once that surgeon has described when he's doing closure, he has to have a control over the decorum of the OT, and the assistant should be following him, so that the discipline or the OT sterility protocols are not broken behind the back of a surgeon. He should be doing wound dressings in a sterile manner, both OPD and IPD. Since NABH has come in, the workload of the file work has gone up, so he has to do all the daily file work and all the daily notes that have to be put in. Occasionally, there are some different camps are there or OPDs there in the periphery. He has to do that. And he also needs to get the pre-op workup done for the patients, all those cardiac workup, PAC, checking all the infection markers before surgery, so that the patients, once he's shipped to the OT, everything is complete inside the OT, so that there are no last moment alarms. He should be very keen on gaining knowledge. He should read about the cases before surgery. He should be asking sensible questions during surgery, pre-op surgery, and he should also be open in giving suggestions. He should not be scared. If he has some suggestions during the procedure, they are most welcome. And he should be always alert during surgery and always follow the flow of surgery. Once you are with a surgeon, you actually know what is his working style. So that is very important to gauge that, so that the surgeon is also comfortable with you when you are having him assisting you. And he should be always ready to ask a question or suggest an alternative path if he feels there is anything we can do differently in a surgery. We expect our fellows to publish 1 or 2 papers, and also publish any special case study if any special case comes during their term. The Indian Joint Registry is coming up very fast, so we expect him to fill all the forms for the patient for the Indian Joint Registry. And he should collect data meticulously post, pre-op and post-op so that we can continue research in the long term after he's left as well. I personally feel it's my duty to break down the goals for my fellow into like clinical, educational, research, future practice building, and life after fellowship. That's the basic difference between a postgraduate and a fellow, because a fellow is soon going to be a colleague for you. So you need to prime him up and prepare him for his life after fellowship as well. We have to teach him all the tips and tricks of surgery as well as other clinical practice. It is actually a mutual bond. So if he is giving you what you want, so you also give him what he wants. We have to prepare him for his independent working, both mentally as well as technically. Decision making has to be taught to him well, what cases to do, what not to do in his early days. And we have to impart life skills as well as his clinical skills. As I always tell my fellows, total knee replacement is not a very difficult surgery to do. It is the difficult part is doing the surgery repeatedly without performing the mistakes and without causing complications. At the end of fellowship, a fellow is expected to confidently expose his joint. He should be confident about the jig placements. He should be able to handle the saw well, because we all know knee replacement is all about good exposure, soft tissue balancing, and proper cuts. So saw handling is very important. He should be clear about all the tricks in the back for the knee balancing, or the upsizings, downsizing, reduction osteotomies, the pike crustings. He should also have knowledge about the computer navigation surgeries, because we perform navigative surgeries here. So he should have a full know-how, like how it is done, everything about the latest advances. He should also know to handle the complications, right? Infections, embolisms, dislocations, periprosthetic fractures, and other wound complications. He should know about the post-op protocols and the physio protocols, and management of the minor issues in the post-op patients, like in the outpatient when they visit or come back. So if I summarize, a mentor is looking to lighten his mental burden, spare time for himself. He is willing to teach with a few expectations from the fellow. He expects the fellow to check on the things which he might miss out due to his mental fatigue or other engagements. He expects intelligent assistance and intra-op advice. And research is equally important during the fellowship. Fellowship is actually fun, both while working and after working as well. And thanks for a patient bearing. And I'll also like to apologize for my sore throat. Actually, I was having a match yesterday. A lot of shouting was there, so my throat is not so well. And thanks for a patient hearing again.
Thank you, Dr. Param. We have a small announcement. Since there were some audio issues on Zoom for the first 4 talks, once the physical meeting ends, like once the Q&A session ends, we'll be replaying the first 4 talks on Zoom. So those who are watching it on Zoom and the other YouTube and other things, they can rewatch the first 4 talks with good audio this time. We'll be going now to the last talk by another mentor, Dr. Adarsh, who is a consultant at Sunshine Hospitals in Hyderabad. Sunshine runs a very extensive program for fellows in arthroplasty as well as arthroscopy, and Dr. Adarsh, being the head of the fellowship program, will talk to us as to what the expectations are and how they choose fellows in arthroplasty and arthroscopy.
Hello, everyone. I'm Dr. Adarsh Annapareddy. I'm an orthopedic and joint replacement surgeon at Sunshine Hospitals. I'm also one of the coordinators of the Arthroplasty Fellowship at Sunshine. I would like to thank the Twin Cities Orthopedic Society for inviting me today and to give this talk on fellowship opportunities for young surgeons and what mentors expect from fellows. So the Sunshine Hospitals orthopedic department is known as the Sunshine Bone and Joint Institute. And our academic offshoot is the SMART, that is Sunshine Medical Academy for Research and Training. And we're also doing some training under the Sunshine Orthobotics
control, that is the robotics department. So you may be knowing this man. He's Dr. Gurva Reddy, our founder, our MD, and the head of the Sunshine Bone and Joint Institute. And his favorite motto is always teach, teach, teach. He completely believes in disseminating knowledge and spreading the clinical skill so that there are so many more surgeons who are well equipped in orthopedic surgery and who can cater to many more people around the country. So because of his passion for teaching, SMART, that is a Sunshine Medical Academy for Research and Training, trains a lot of different orthopedic surgeons. We have a DNB ortho, we have primary and two secondary DNB ortho seats every year. We have the arthroplasty fellowship. We have hundreds of surgeons coming all over the country over the last few years. Then we have recently started a trauma fellowship. This is our first batch of trauma fellowships. We have an arthroscopy fellowship in knee and shoulder. We have a spine fellowship, as well as robotics now, which is clubbed into our arthroplasty fellowship. So I would like to take this opportunity to just give a glimpse of our different fellowship programs. So young surgeons who want to get in touch with us, who don't know how to go about it, can have some idea of what we offer and how to go about it. So we have a trauma fellowship. We have the wonderful surgeons from both branches, Secunderabad and Gachibowli. You may be knowing them. We have stalwarts in foot and ankle, pelvic, hand, and the whole gamut of trauma surgery. With 3 fellowships every year, 11 months in the trauma department and 1 month of another subspecialty. And you have to be at least post MS or DNB ortho. And interviews are done by our trauma consultants to select. And this is a contact number in case you want to get in touch with us for the fellowship in trauma. Then we have our arthroscopy fellowship, where they cover both arthroscopy of the knee and the shoulder. There are 3 fellowship seats every 6 months. And again, at least 1 to 2 years post PG. And selection is again done after interview by our scopy consultants. They teach both in OPD as well as OT, MRI reading, clinical examination, post-op rehab protocols, and you do get hands-on arthroscopy exposure in both knee and shoulder, where they cover the whole gamut of knee, ACL, MCL, meniscus, patella, and shoulder, rotator cuff, and tendon transfers, and instability like Bankhart's repairs. Then we have a Sun Spine Fellowship. That's over the Sunshine Spine Department. We have 1 fellowship every 6 months, and the duties get rotated in the theater and OPD, and you get an opportunity to be part of the research studies. Again, it is 1 year post PG experience is required, and they have to maintain a complete logbook, and final evaluation is done. The aim, again, they teach both cervical, thoracic, and LS spine, and to enroll, this is the number. Now, our most sought after fellowship is the arthroplasty fellowship. You have stalwarts in the field of arthroplasty, teaching both knee and hip arthroplasty. And these are our program coordinators. There have been hundreds of surgeons have benefited from the arthroplasty fellowship over the last few years. And here we do this under the aegis of 3. One is our own Bone and Joint Institute fellowships. We have 8 in the January batch and 6 in the July batch. And you have 1 ISHQ rotating fellow and 1 SIA, that is a South Indian Arthroplasty fellow, who rotates 6 months in Sunshine, 6 months at Sparsh Hospital in Bangalore, 6 months at AJRI Chennai, and 6 months at Ganga Hospital, Coimbatore. So the eligibility criteria, again, at least 1 year post MS or DNB with an MCI registration is very, very important. And here we select our applicants after they send in a current CV, educational qualifications, at least 3 letters of recommendation, and any peer-reviewed publications definitely gives weightage when we are selecting. We used to have a written exam, but now after the pandemic set in, we're doing video calls, and we are interviewing each and every patient, each and every candidate who has applied. To approach us, you can email to this fellowships@sunshinehospitals.com. You can find this and you can get more details on our Sunshine website. Again, here where you're exposed to all different types of arthroplasty, primary hip, primary knee, and unicondylar knee replacement, hip preservation surgeries, revision, and also now we have robotic assisted knee and hip surgeries as well. You'll be rotated between both Secunderabad and Gachibowli branch over a span of 1 year. You get OT days, at least 3 days a week, and the rest of the days you'll be in OP and research work and also on-call duties. And fellows are expected to and are also encouraged to go to other departments as well, like trauma, Elizarov, and sports medicine as well. The educational program, we have weekly meetings, journal clubs, presentations, seminars, and pre and post-op X-ray discussions. And we also have a monthly meeting with the SIA institutes as well, where you get to interact with all the stalwarts of arthroplasty who are part of the SIA. Research is very, very important. We all fellowship trainees are assigned a research topic, and before they leave the program, they have to have at least gotten one paper ready for publication. So now let's move on to the next part of the talk. What do we expect as mentors? So yeah, with providing all these different fellowship opportunities, there's a lot of burden on the mentor. But at the end of the day, we also want to get something in return. We want to get some support from the fellows as well as mentors. So I've divided this into before joining, what we expect, while you're here with us, what we expect, and after you leave, what do the mentors expect. So before joining, we expect at least 1 year post PG, that is either MS or DNB. Otherwise, you'll end up like Doogie Howser, a young orthopedic surgeon moving around the hospital, wet behind the ears. You need to have at least 1 year of post PG experience. That's when you get the maximum benefit out of this program. And we also get the maximum benefit out of your experience of at least 1 year, either in a trauma department or even where you have done your PG. If you have some exposure, that definitely benefits both. Then, as I mentioned, some exposure to arthroplasty or whichever branch you're applying for, either trauma, spine, some carpentry work should have been done at least for a year or two before you join with us. Again, basic theory knowledge is extremely important. In our written exam, as well as our interviews, we do ask some basic questions. You don't need to have read Insal and Scott before joining, but at least a basic Campbell. If you have the basic ideas, you'll be able to get through our interview process. We prefer younger candidates. I mean, who are ready to work, because it is a strenuous job. Orthopedics itself is strenuous, and our fellowship programs are quite hectic. We do start sometimes 4:30 to 5 a.m. and sometimes end like 6 to 7 p.m. I secretly took a picture of one of our own fellows, a poor chap, after working the whole day. This is not before work. This is after doing a good day's work, taking a bit of a rest in between cases. Okay, and commitment, most important thing, we need commitment to complete the course. We don't want somebody who comes, has a glimpse, gets scared and runs away like this. We need somebody who's willing to commit, because it's a long course. We have at least 6 months. So the arthroscopy is 6 months, but our arthroplasty fellowship is 1 full year. So you need to be able to commit to your full 1 year course. So while you're with us, what do we expect as mentors? We expect punctuality. So our fellows come in sometimes at 4:30 a.m., get the positioning done, shift the patient, get the positioning, do the scrubbing, get the painting done, and get the patient ready in time for the incision. Because we have very high loads, everything needs to work like clockwork. So punctuality is extremely important. Well dressed and presentable. And of course, our fellows are not always dressed like this in suits. This is our outgoing batch. But definitely our team, our mentors, we expect at least, good formals. Sometimes a tie is also appreciated, and good clean aprons. We're very, very particular about how presentable our fellows are. The most important thing is the fellows must always maintain the ideals and beliefs of the hospital. So our main ideal, our main belief at Sunshine is patient first. We give these badges to all our registrars and nurses, but also our fellows, and they need to emulate that. And this is Dr. Gurvareddy's most famous motto again, is patient first, patient first, patient first. So all our fellows get this badge, and they have to implement this patient first. The beliefs of the hospital should always be protected and followed by the fellows. Sincerity of work, it obviously, you don't need to say it. This is our huge OT list. You can see this whole thing is our OT list, and our hardworking fellows from morning till evening, they're slogging, but that's how sincere they are, and that's what we expect as mentors. Active participation in academics and utilization of the resources. We have good libraries, and most places where you go for fellowship, they will have very good libraries with journal access. You should utilize your time that you're here and make sure that you get the maximum out of the resources that you have. Research. Most important part of any fellowship is research. It benefits both the fellows as well as the organization, the institute. And this is our picture of our fellows just getting ready for their research presentations, our bi-weekly research presentations, to make sure that their papers are on track for publication. It's the most important thing. Make sure that you do concentrate on this. Data collection. Again, this is one place where the fellows can really
give back to the institute that they're learning. All our patients, the data is collected. We make sure that the proformas are filled up and they're done in a genuine way. Again, this will help the fellow himself, it help him in his research topics, and you can make sure that you get a publication before you leave. Very, very important thing, keep on asking questions. As I said, we have weekly webinars, but not just during the webinars. I say even during the OT, when you're assisting, when you're sitting in the OP, when you see something on the X-ray that you haven't understood, you should always keep on asking questions. You have to utilize the time that you're spending away from your family so that you get the maximum benefit out of it. Never ever criticize another surgeon's work in front of patients. This is what we have learned from Dr. Jawhar Reddy. Even if you see an X-ray looking like this and you find something off, don't discuss in front of the patient. Let the patient know that everything is good. And then you can, if you want to discuss, you can probably sit back with your colleagues or with your mentors and try to find out what is wrong here. How could it have been done better? But not in front of the patients. They will get alarmed as well. So after you leave, what do we expect as mentors? Like, everything is done. Why would we care about what happens after you leave? Well, we want you to practice and implement what you have learned, all your surgical techniques and patient interactions, how you have learned over here. We don't want you to end up again like an orangutan with a saw working on a piece of wood. That's not how we want you to be. We want you to make sure that you implement all the finer nuances that you have learned along when you're with us. Then most important thing is spread the knowledge. The olden days, I think people used to try to hold the knowledge back in a vice grip. It's not like that anymore, especially at Sunshine. We believe in spreading the knowledge. We have fellows from all over the country who have their own great practices running right now, and they're teaching other surgeons. And now we're trying to, basically at the end of the day, we have to cater to the people of the country, all over the country. Most important thing, keep the flag of the institute flying high. When you're going to a prestigious institute, not just Sunshine, anywhere around the world, you are becoming a part of there. You're becoming an alumni of that place. When you leave, when you operate somewhere, when your results come out, it will reflect on where you have learned, where you have trained. So if you want to keep the flag of your institute flying high, you should implement whatever you have learned and follow all the principles that you have been taught. Thank you so much for this opportunity.